Good morning. So today we're going to talk about endocrine emergencies, which honestly don't come in with a big sign that says endocrine problem. These patients usually roll into the emergency department with altered mental status, hypertension, weakness, or vague complaints or symptomatology. And so that's why these diagnoses get missed. What makes them dangerous is that they often look nonspecific early, but once they decompensate, they can do so very quickly. The good news is that many of these conditions are highly treatable, and if recognized early, they can be saved. So today, I want you to listen to me with an emergency medicine mindset. What's killing the patient right now, and what can I fix fast? These objectives are really about clinical thinking, not memorization. So I want you to be able to see a patient and recognize when something feels physiologically off, even before labs come back. Many of these conditions require treatment based on suspicion alone. In emergency medicine, we don't get the luxury of perfect certainty. By the end of this lecture, you should be able to be comfortably able to start treating patients while you're still sorting out the diagnosis. We'll start with hypoglycemia. It's common, fast, and fixable, and frankly, missing it is catastrophic. Then we'll move into diabetic emergencies like DKA and HHS, which you will absolutely see in the emergency department. From there, we'll transition to thyroid and adrenal crises, which are rarer but much more lethal. You'll notice a pattern across this lecture. Many of these conditions overlap in symptoms. The key is learning how to separate them using physiology and response to treatment. Hypoglycemia is both a lab diagnosis and a clinical diagnosis. Sure, we use in numbers, as you can see here on the slide, but what really defines hypoglycemia is a symptom resolution when glucose is given. In an altered patient, you should never hesitate to give glucose. It's fast, safe, and diagnostic. Waiting for confirmations can result in permanent neurologic injury. Think of hypoglycemia as one of your must rule out causes of altered mental status every single time. These risk factors that you see should immediately trigger suspicion in your head. Diabetic patients on insulin who aren't eating well are classic. Elderly patients are particularly dangerous because they don't always get those early warning symptoms like tremors or palpitations. Alcohol use is huge. It both lowers glucose production and masks symptoms. So if you hear diabetic, missed meals, or alcohol, hypoglycemia should already be on your differential. When glucose drops rapidly, the body releases catecholamines in an attempt to preserve brain function. That's why early symptoms look like anxiety, tremor, sweating, and palpitations. But as glucose keeps falling, the brain simply doesn't have the fuel. And that's when you see confusion, bizarre behavior, seizures, or even coma. These patients can easily mimic stroke or intoxication. Treating the glucose often makes the entire neuro exam normalize. A fingerstick glucose should be as automatic as checking the blood pressure. Any patient with altered mental status, period, gets a bedside glucose test. This should happen at triage or even in the ambulance. If you remember only one thing from this lecture, remember this. Missing hypoglycemia is a never event. It's one of the fastest diagnoses you can make. Dextrose uh, corrects hypoglycemia quickly, but it doesn't last. That's why recurrence is so common if you don't follow with maintenance glucose or oral intake. Once a patient is awake and can swallow safely, oral carbohydrates are ideal. Glucagon will only work if glycogen stores are available, which is why it often fails in alcoholics and malnourished patients. If glucose keeps dropping despite treatment, you need to widen your differential. Diabetes mellitus is really a spectrum of disorders that all lead to hyperglycemia. Type 1 diabetic patients lack insulin entirely, which is why they're prone to DKA. Type 2 patients may have insulin, but it doesn't work very well, so hyperglycemia develops slowly. Gestational diabetes matters because it affects two patients at once, the mother and the fetus. Understanding the type helps you anticipate the type of emergency the patient is likely to develop. This slide is important because not all diabetes fits the textbook picture. Steroids are one of the most common causes of secondary diabetes you'll see in the emergency department. Pancreatic disease can knock out insulin production entirely. Monogenic diabetes often affects younger patients who don't appear insulin resistant. When the story doesn't fit, think outside of type 1 and type 2. Type 1 diabetes often announces itself loudly, with DKA triggered by infection or stress. Type 2 diabetes, on the other hand, often whispers for years. It comes off subtly. Patients may come in for recurrent infections or neuropathy before anyone checks a blood glucose level. The ED is frequently where diabetes is first diagnosed. I want you to always keep that in mind with vague multi-system complaints. Diabetes is a full body disease, so your exam needs to match that. Okay, look at the feet. Ulcers and infections are going to tell you a lot of information. So I want you to check the pulses and skin temperature for any type of vascular disease. Neurologic deficits explain falls and injuries. Even a quick targeted exam can give you valuable clues. In the emergency department, we're not managing hemoglobin A1Cs. We're managing crises. Acute hyperglycemia often improves with fluids alone. True emergencies are DKA and HHS, which require aggressive treatment. Every severe hyperglycemic emergency has a trigger, most often infection or noncompliance. Finding that trigger matters just as much as treating the glucose. Hyperosmolar hyperglycemic state, HHS. This is really a dehydration crisis with extreme hyperglycemia. These patients still have some insulin, which prevents ketone formation. Instead, glucose rises to incredible levels, pulling water out of cells and causing neurologic symptoms to occur. Mental status changes are common and often severe. These patients usually present late and are very sick. HHS tends to affect older patients who can't access water or recognize thirst. Okay, infections are common triggers. Patients on diuretics, that's going to worsen their dehydration. Social isolation plays a huge role. Many of these patients live alone and decompensate over days or weeks without being noticed. Always ask how long have symptoms been going on and also their home situation as well in these patients. These patients look profoundly dry. Poor skin turgor, dry mucous membranes, hypotension. Neurologic deficits can be striking and often look like stroke. Hypothermia rather than fever is a bad prognostic sign in this situation. Always think about what pushed them into this state. The exam screams dehydration. Okay, that's your physical exam. When working up HHS, their workups are highly extensive because nearly every system is affected. Electrolytes guide fluid and potassium replacement. Osmolality explains neurologic symptoms. Cardiac enzymes and EKG assess ischemia. Cultures help identify infections. Expect abnormal results across the board. Fluids are absolutely the cornerstone of treatment. Starting insulin before fluids can worsen hypotension. Just rehydrating these patients alone can dramatically lower their glucose. Potassium replacement is also critical to prevent arrhythmias. Correction must be slow and deliberate in these patients. DKA is a true metabolic emergency. It's driven by insulin deficiency. Without insulin, the body shifts to fat breakdown, producing ketones and acid. Osmotic diuresis leads to severe dehydration. The combination of hyperglycemia, acidosis, and volume depletion is what makes this so dangerous. Early aggressive therapy will help to change outcomes. These patients are dehydrated, tachycardic, and tachypnic. Abdominal pain and vomiting are common and can sometimes mimic cerebral pathology. Kussmaul respirations reflect respiratory compensation for the acidosis that's present. Mental status changes signal severe disease, so always consider ICU level care in these patients. Volume comes first, always. Insulin is essential but dangerous if electrolytes aren't managed appropriately. Potassium can plummet rapidly once insulin starts. Insulin um, when administered, pushes the potassium out of the cell. Remember that from the diagram we discussed? So frequent assessment is everything. DK resolves when the anion gap closes, not when glucose normalizes. Most complications regarding DKA come from correcting things too fast. Cerebral edema, although rare, is devastating. Electrolyte shifts can cause lethal arrhythmias. Acute respiratory distress syndrome can occur with aggressive fluids as well. So slow and steady wins DKA. Next is alcoholic ketoacidosis. AKA occurs when chronic alcohol use stops suddenly and intake drops. These patients are often vomiting and malnourished. Unlike DKA, glucose is usually normal or low. Mental status is usually and typically preserved. Treatment is straightforward once you recognize the AKA patient. Symptoms are going to overlap with gastritis and pancreatitis, so it's easily missed. Significant mental status changes should push you to look for another cause. Elevated anion gap is a key lab finding. Liver enzymes are often abnormal, and volume depletion helps to drive the severity of the issue. This slide here is stressing the importance of being able to calculate the anion gap, specifically with the acid-base balance. It's something that needs to get calculated because alcoholic ketoacidosis can be missed, and it's dangerous when it's missed. So, key focus of this slide is the elevated anion gap and the low or mildly elevated serum glucose levels. Okay, but when discussing the treatment for AKA, D5 normal saline is the fluid of choice. Why? Because it stops ketone production or gluconeogenesis. Insulin is not only unnecessary but dangerous. Thiamine should be given early to prevent Wernicke's encephalopathy. Electrolyte replacement is often required, and patients typically respond quickly to this treatment. Moving on to the thyroid gland, we're going to discuss hyperthyroidism first. Graves' disease accounts for the majority of cases. Younger patients often present with obvious symptoms, while older patients may not. Medication and iodine exposure can worsen disease. Hypothyroidism affects every system, as you may know. So I want you to think broadly when evaluating these symptoms. The most common heart rhythm associated with thyroid storm is atrial fibrillation. Um, Thyroid storm is a clinical diagnosis. Your labs are going to confirm the hyperthyroidism, but don't define storm per se. Fever, tachycardia out of proportion, and AMS are hallmark findings. Atrial fibrillation is common. Mortality is high without treatment. So I don't want you to wait for labs. Okay, if you notice fever, tachycardia out of proportion, and altered mental status, combined with an EKG showing that there is atrial fibrillation, it's going to lead you to thyroid storm. And in this situation, early treatment is going to save lives. The Birch-Wartofsky point scale, this is a clinical scoring system. It's basically a tool that we use to help support our reasoning. High scores will justify aggressive treatment. It should never delay your therapy. It's basically a scoring system to help us quantify how sick the patient is. So use that as a tool, not a gatekeeper. Treatment targets multiple steps of thyroid hormone action. Beta blockers control adrenergic symptoms. Thiamides block synthesis. Iodine blocks release, but must come later. What is essential is supportive care. That's what's going to help the patient. An ICU admission is not only required, but also critical. Most hypothyroidism is diagnosed and managed outpatient. Hashimoto's is the most common cause. Medication review is critical in these patients. But emergency presentations of hypothyroidism are rare, but they are dramatic. Keep this in mind when patients start to decompensate. Myxedema coma. This is a medical emergency with a high mortality rate. We will see decreased mental status, hypothermia, and other symptoms related to slowing of function in multiple organs. Myxedema coma will occur when the body's compensatory responses to hypothyroidism are overwhelmed by a precipitating factor such as infection. Okay, this is the extreme end of hypothyroidism. Patients are cold, bradycardic, and obtunded, and your diagnosis is going to be clinical. Okay, even with treatment, mortality remains high in these patients. Airway and circulation come first when treating myxedema coma. IV thyroid hormone is also required, and the steroids will protect against adrenal insufficiency. Rewarming the patient should be passive, and once again, these patients will require ICU level care. Okay, so Addison's disease. This leads to deficiencies in cortisol and aldosterone. Symptoms develop slowly until a crisis occurs. Autoimmune disease is the most common cause. Many patients are undiagnosed until they collapse. That is why early recognition is critical. Okay. Secondary adrenal insufficiency. This involves the HPA axis. Okay, so the pituitary is dysfunctional rather than adrenal failure in this situation. Aldosterone is going to be preserved, which changes the presentation on these patients. Chronic steroid use is the most common cause, and symptoms are subtle and easily missed. But stress is going to reveal the deficiency of the hormone. Next up is adrenal crisis. It will present as shock that does not respond to fluids or pressors. Abdominal pain can also mimic surgical emergencies in these patients. Hemorrhage is going to cause abrupt collapse as well. This diagnosis is often missed, so you must treat early to save the patient's life. I don't want you guys to wait for confirmation. Just don't wait for labs. If you suspect adrenal crisis, give steroids immediately. Hydrocortisone is the one of choice. It's going to treat both these deficiencies. It's safe and life-saving. You can order labs later after the fact. Pheochromocytoma crisis. Okay, this always ends up on your exams in the PANCE and PANRE. These tumors cause massive catecholamine surges. Hypertension can be episodic or sustained. Complications include stroke, MI, and pulmonary edema. Your diagnosis is going to require labs and imaging, but the acute management will focus on blood pressure control. Now, as far as management is concerned, alpha blockade must always come before beta blockade. Beta blockade, this is non-negotiable. But surgery is definitive cure for this, okay, removing the actual tumor. Poor preparation leads to catastrophic outcomes. So you need to consult a multidisciplinary team in these situations. It's key to the patient's health and safety and prognosis. So your recognition of these findings is going to help prevent a disaster in this patient. When we discuss severe hyponatremia, it's the symptoms class, not the sodium number. That is going to help define severity. Cerebral edema is going to cause neurological findings, and the volume status is going to help identify the cause. When seizures develop, it is an emergency, so your correction must be slow and controlled. Treatment is with hypertonic saline. This is reserved for severe symptoms. Rapid correction will cause osmotic demyelination of the brain. Chronic cases require caution, so I want you to treat the underlying cause. Serial monitoring is going to be essential in these patients. These endocrine emergencies are dangerous not because they're rare, but because they're subtle. So I want you to understand that early recognition and physiology-based treatment will save lives. Trust your clinical instincts. When treatment is low risk and high reward, don't wait. This ends the presentation. Thank you.